Chapter 30, Disorders of the Hepatobiliary and Exocrine Pancreas Function. So the functions of the liver related to metabolic would be to metabolize carbohydrates, protein, and fats. We know that sugar gets stored as glycogen and converted to glucose and used to make fats. We know that proteins are synthesized from the amino acids, and ammonia gets made as a byproduct into urea. We know that fats are oxidized for energy, synthesized, and packaged into lipoproteins. Glyconeogenesis is where the amino acids are used to make glucose. Ammonia, again, is the byproduct, which is particularly toxic to neurons. Urea is excreted by the kidneys, if the kidneys are functioning. The liver also serves as a detoxification organ. It also plays a role in drug and hormone metabolism. Bile is produced in the liver. We convert ammonia to urea so that it can be excreted. And in the liver, we store our fat-soluble vitamins A, D, and K. When the liver is failing, we see signs and symptoms related to the functions that the liver takes care of. So when we have liver failure, we may see hematological disorders such as anemia, thrombocytopenia, coagulation defects, and leukopenia. We may also see in liver failure certain endocrine disorders resulting in fluid retention, hypokalemia, and disordered sex functions. We know that the diagnostic test that we do to determine liver function is the AST and the ALT. If these are elevated, it indicates liver dysfunction, and they rise and fall in a parallel manner for most part. Other signs and symptoms that we see with liver failure would be skin disorders. We see jaundice, particularly in the elastic tissue and the sclera in the eye, and that's related to the increased bilirubin that's floating around in the blood. We may see hepatorenal syndrome, where we see azotemia, an increased plasma creatinine, and lack of urine production. And in the extreme cases of liver failure, we see hepatic encephalopathy when we have liver failure, where we see asterix, which is the flapping around, confusion, coma, and convulsions. Other types of liver disease include hepatitis. You do not need to memorize all the different kinds of hepatitis. We're primarily going to be concerned about hepatitis in terms of the transmission and whether we have vaccines or not to prevent. So in viral hepatitis, hepatitis A, hepatitis B, and hepatitis C are probably the most common hepatitis that we see. We know that hepatitis can be either an acute or a chronic inflammation of the liver, and that alcoholism, autoimmune disorders, and medications, drugs, both legal and illegal, put patients at risk for. So chronic viral hepatitis, usually caused by hepatitis B or hepatitis C, is one of the principal causes of chronic liver disease and cirrhosis in the world. It is also the chief reason for liver transplant in adults. It's usually related to, in terms of the different types of hepatitis, they have different, as I said in the last slide, they have different presentations, they have different routes of transmission, and the ability to have a vaccine to treat them or prevent them is present. So in hepatitis A, we usually see this as a short-term type of hepatitis, generally transmitted through a fecal-oral route of transmission. Generally, we associate hepatitis A with food and unclean preparation sites. There is a vaccine available for hepatitis A. Hepatitis B and C are transmitted through needles, blood, and sexual contact. So think of blood in terms of dirty needles and drug use. These both have vaccines available to, hepatitis B has a vaccine available, and as healthcare workers, since we are exposed in our workplace to these conditions, we are required to get a hepatitis B vaccine. Hepatitis B and C does have what is known as a carrier state, where there are no symptoms, but they are carrying hepatitis. People with impaired immunity or that are on hemodialysis or have hematologic disorders such as sickle cell are at high risk for being. There are phases of viral hepatitis. Generally, hepatitis A lasts about 9 weeks, where hepatitis B ends up about 16 weeks. It goes through a pretty stable stage process. We have the prodromal or pre-icterus phase, where they feel fever, malaise, anorexia, mild aches and pains, nausea and vomiting, and diarrhea, but they do have diagnostically elevated AST and ALT levels. In the icterus phase, which is usually about 5 to 10 days after the prodromal phase, is where we get the jaundice and the pruritus, the itchiness, and the liver tenderness, and this is where the bilirubin becomes elevated. And in the convalescent phase, which is about 2 to 3 weeks, we see a steady resolution of symptoms and a return to normal. Alcoholic liver disease can present in 3 different presentations, with cirrhosis being the end stage liver disease with no recovery possible except transplant. In a fatty liver, we see that the liver becomes enlarged because of fat deposits. Generally, there's no symptoms to this, and it can be reversed by changing diet. An alcoholic hepatitis is where we see liver inflammation and liver cell failure. The signs and symptoms include ascites, anorexia, jaundice, and encephalopathy. These are prominent changes that usually are not reversible, but can be prevented from getting worse by quitting drinking. And cirrhosis, the end-stage liver disease, is where we actually have scar tissue replacing the internal sinusoids of the liver, creating for lack of a better word, like kidney stones, but they're bile stones in the liver. There are nodules that swell and compress the hepatic vasculature, and this is what creates the portal hypertension. The portal hypertension in turn causes esophageal varices. Again, leads to the ascites, the big abdomen, hard with large girth, and a backup into the spleen, so that the spleen becomes enlarged also. In end-stage liver disease, there are severe coagulation disorders. Oftentimes these patients enter the hospital through the emergency department in acute distress, hemorrhaging. It takes us quite a bit of time to try and stop the hemorrhaging, and large amounts of blood are lost. Nice picture of how portal hypertension takes place and what other things are involved. Disorders of the gallbladder. We call it cholelithiasis, where we have gallstones. We have acute and chronic cholecystitis, where we have inflammation caused by irritation due to concentrated bile. We have cholelithiasis and cholangitis. Most of the time when people come into the hospital for surgery, they are getting gallstones taken out. Gallstones are made up of cholesterol and calcium salts, or a mixed bag. Cholecystitis is oftentimes secondary to gallstones. Patient profile is the 4 F's: fat, fertile, female, fair. So most often seen in white Caucasian women. We know that there is a familial link here that could be environmental. But if your mom has had gallstones, you are at risk. Signs and symptoms include pain in the upper right quadrant, or epigastric or back area, with referred pain to the shoulder, right shoulder. It is abrupt in onset, and it persists for about 2 to 8 hours, and it is significantly impacted by fatty foods, eating fatty foods. On diagnosis, we see this in a CT scan, and the treatment is surgical or laparoscopic, open or laparoscopic removal of the stones. Not life-threatening. Chronic pancreatitis and pancreatic cancer. Both have the similar signs and symptoms. Upper left quadrant pain, often precipitated by alcohol or overeating, nausea, vomiting, gas. As the disease progresses, you may begin to see signs and symptoms of diabetes as the exocrine and endocrine functions of the pancreas fade away. Weight loss, fatty stools, which we call steataturia, occur with both of these disease processes. Treatment is putting people on a low-fat diet and treat the underlying malabsorption with TPN. Sometimes we need to give patients pancreatic enzymes and insulin to combat the problems that have occurred because of the damage to the pancreas. And under no circumstances can these people drink. When we're talking about pancreatic cancer, this is one of the most deadly cancers that exists today. 4% of the population that gets pancreatic cancer has a 5-year survival rate. We don't know what the cause of pancreatic cancer is, but we do know that it is linked to certain genetics. So the BRCA, BRCA1 gene is linked to pancreatic cancer also. We know that pancreatic cancer occurs in individuals greater than 50 years old, generally with a history of smoking